So the goal of this is so that we can hear from people who are performing well. Lee is one of our initial medic members who's been working on this. He's a dual trained both emergency medicine and pediatric emergency medicine physician and a lead at St. Joe Mercy in Ann Arbor. And so we thought it would be really helpful, since we understand the context of having a lot of generalists having to struggle with, employing a pediatric measure, or specifically in the intermediate head injury group, to hear from somebody who has a foot in both worlds. So Lee, take it away.
All right. Well, thanks for the opportunity to present. And I want to make a disclaimer. We had been working on this as a quality initiative before the MEDIC QI collaborative, before we joined. So we really haven't seen a lot of great improvement since joining. However, we had identified before joining the collaborative that this was an opportunity. And once we started measuring our baseline, we discovered in both the low and intermediate risk categories, there was some room to improve. So you can see there that since we started measurement in 2017, we've been doing pretty steady. And we've had a couple of challenges, and we have some new challenges that we're facing currently with staffing. And I just wanted to share kind of what we've done, what we've found to be successful as we've gone through this. One of the main challenges, and although we are a general emergency department, we have a nested pediatric unit within the greater emergency department. And that's both a good and a bad thing in a couple of ways. The good is that we had pediatric nurses, pediatric staff who are dual trained or pediatric trained, who really embrace this and kind of get it from a pediatric standpoint. They were all on board very early on, so we were able to really decrease our CT utilization rates. However, with current staffing challenges, with the decrease in pediatric patients presenting to the ED, we've kind of shortened our hours in the pediatric specific unit. So our general providers and general nurses are now seeing kids that would have been eaten up by the peds team before. So they're seeing these kids, and this is a fairly rare condition. We're finding when we look at the data, and it's something that they just don't see a lot of. So provider comfort and familiarity with the rule has been really important in maintaining kind of where we're at. So what we did early on was we generated a shared decision-making tool. We can go to the next slide. We had providers follow the PCARN data, and we created this talking points sheet for shared decision-making with our families, so they knew how we were making decisions. This is an example of the lowest risk category, and I want to point out some of the language that we're using on this. So although PCARN defines their lowest risk category as simply low risk, the one in several thousand, we don't feel that's really accurate in talking to families. So we describe this category as very low risk. This is the category where there really shouldn't be much discussion. These patients do not need a CT. Let's go to the next slide. Now, this is what PCARN refers to as the intermediate group, but we all know the intermediate group is still less than 1%. And based on which specific risk factor you have, it's probably a lot less than 1% if it's only one risk factor. So understanding that has really helped our providers. And when they score patients using the PCARN tool into this realm, we call this our low risk group when we're talking to parents, because less than 1 in 100 we still think is a low risk, even though it was intermediate in the original PCARN data. And this provides opportunity to talk to the parents and do some shared decision making. And I think this has really helped, showing them this diagram that, gosh, we would have to do CAT scans on 100 kids, probably even more, to pick up that one patient. And when they see this, they kind of pause, and it allows that discussion. In the PCARN data, I think PCARN made it too easy to scan people in this category. In the original documentation in this group, it says you can observe versus CT. And that's in the diagram from the original article that a lot of providers see. And it's an easy opt-out to get CAT scans. And what we're really working on is helping people understand that this is an area where we should really be observing prior to going to CAT scan. So that's where a lot of our focus goes. Some of the barriers to that have been pressures to see patients quickly, move them, open up beds, especially during this surge. Bed space is certainly a scarce resource. But observation is really a key in working with this. So what we've been doing is we've really had to work with our providers to continue education multiple times through multiple venues, give them cards to look at real time. They're taped on the main computers in all the units, training our residents to follow evidence-based guidelines. And it seems to be working pretty well in maintaining where we are. A few things that we've also done that have really been helpful are to give pointed feedback to those providers who are falling out pretty significantly and getting more CTs than the rest of the group. So they get private notifications, they get the cases, they get our questions. And what's been crucial in developing that is our abstractor, Nancy Wu. I'm not sure if she was able to join us. She's on vacation. She shouldn't be joining us. If you're on the line, Nancy, it's vacation. But what Nancy has done is goes through every case to identify who's the ordering provider. So instead of just a clump of CAT scans attributed to an attending, we're trying to find out, was it a PA or a nurse practitioner? Was it a resident? Was it the attending? Because they really desire specific data to them. Otherwise, it doesn't matter. It's meaningless. I didn't order that. It was the APP working under me that shift. Don't come talking to me. So we've really had to do a lot of work to go into each individual chart and manually abstract that. That has been a monumental feat and really helpful in our discussions with our providers. So we talk to them privately if they're a fallout. We recognize our champions publicly during the business meetings by having their names up there as, you know, the 100% club, everyone who was right on with what they should have been doing following this guideline. We also have, for other QI measures, shared unblinded data, and this is really powerful to see a bar chart with you compared to the rest of your peers. We've done that in the past for other measures such as PE in an unblinded fashion where you're assigned a random number, but we've also done it unblinded. So everyone knows where everyone else sits. We're not quite ready to go there. I think during this time, a lot of staff around the state are a little bit fried. I'm not sure we're really ready to go to that for this metric. Especially as we're doing pretty well, we haven't deployed that quite yet. What we could really utilize, and where I think we're going to see over the next 5-10 years a lot of movement, are real-time clinical decision support. So you open up your Epic, and Epic pulls in head injury, and instantly, boom, you get your PCARM score, and based on clicking the score, boom, it takes you to a recommendation. And I think that's the sort of thing that would really help us. I know some institutions have dot phrases and such that are easily deployed. We are yet to be able to make that as part of a big organization of Trinity with 90 hospitals, I think, around the country. Anything you do at one Trinity site has to apply to all Trinity sites. And as we learn more about Epic, we look forward to utilizing that. The last thing that I would say in getting the group to participate and engage in this is really identifying your core providers who are considered as influencers of the group, who people trust, who people listen to, who aren't branded with leadership titles like director of the pediatric unit. Find those people who work a lot, don't have heavy administrative loads, learn from them, highlight their successes, let them speak to what they're doing and why they bought in to it. And that, I think, is also a very powerful story to share. So that's where I will leave it. I'd be happy to take questions. Unfortunately, there's an ASAP meeting I have to jump to in a few minutes, but happy to stick around for a few.
Thanks, Lee. That's awesome. Is there any questions from the collaborative members on the call? Okay, Lee, I have one for you. Oh, go ahead. Who was about to ask something?
This is Sarah Shackle from St. Mary's, Livonia.
Go ahead, Sarah.
I have just a question about when we're going through our data, we do not see very many peds head injury cases. So usually it just takes one scan to put us either in compliance or quite horribly out of compliance. I don't know if Dr. Benjamin or if anyone else could address this. In terms of talking, we find that a lot of our pediatric patients go through our split flow section where mainly there's PAs or NPs working, occasionally residents. But is there any thought from Dr. Benjamin or the group about whether it's helpful to meet this metric, to say, like, if you're going to order a CT on a kid, it has to go through an attending level decision or something along those lines? We're just kind of struggling how to move the needle at our site.
I'd be happy to take a go at that, Michelle. I'd love to hear what other people are doing as well. I think that's an innovative approach. Let me give the background from our experience. When we started looking at these and identifying the ordering provider, it wasn't a problem of APPs. It wasn't a problem of residents. It was a problem of everybody. It was the attendings, the residents, the APPs. So I think uplifting kind of the expectation for everyone was what worked and continues to work with us. We're right in the same place you are right now, as we have truncated our hours of the PEDS providers being present just to get the bulk of patient presentations. Our APPs are picking up a lot of those well-appearing kids who go through our split flow as well and have to do decision making. We haven't asked them to staff all of these patients. They commonly do, just because they traditionally haven't seen a lot of kids. So they run it by the attendings. It may or may not be an attending with some pediatric training, but we haven't mandated that. We do provide the tools everywhere. Again, they're taped to the PA and APP's computers. We've got the cards scattered throughout the ED. We have the shared decision-making tools around that. We just have to kind of keep reinforcing these are there. And so far, so good. But we haven't gone that far as to doing that. You know, part of me thinks we work very closely with our APPs and we want to respect their decision making as well. I think they're very good at what they're very good at. I think this may be a point where you could have, if you can identify the specific providers, have those one-on-one conversations, share the data, share the expectation. And some of the most powerful discussions are that category where the patient may only have one of the fallout criteria, and sharing, gosh, this patient only had X. That would lower their risk to well less than 1 in 100. It would be closer to 1 in 400. So then you can start making the argument, let's think, do we really need to CAT scan 400 patients for this one? So that may be a place to deploy those conversations. I'd love to hear if other people are doing this. It's an interesting idea.
I just want to open it up to the room here and does anybody else have any innovative ideas with respect to how you work with your APPs or your trainees? Be interesting to hear.
Yeah, this is Sarah again. I just want to clarify. I think that our fallouts tend to be in the APP world only because of how we staff our department and where these kids get triaged to, not a specific comment on a class of clinician in the ER.
Lee, just go ahead, sir.
Oh no, that's it. That's it. I just want to make sure that that didn't come across the wrong way.
Nope, no, nothing taken negatively at all. We're all here to share.
I work with a lot of those same APPs. I know.
Hey, Lee, I have a question then for you. So take it up a level with APP communication of like quality metrics. Do you meet regularly with quality measures and relay those to the APP? If so, how do you do that?
It's a good question. So our APPs are considered part of our staff, and at every business meeting, we report out on the QI measures. And when we have the capacity to really strip it down, and we've made a big point of doing this and attributing ordering propositions such as this to the person who ordered the study. And I think that's been key to it. So we have had our APPs, we've shared that data, both blinded and unblinded, in just the APP cohort. So we have one cohort for the docs, one for the APP, so they can compare themselves kind of like for like. We're not quite at the point where we've mixed everyone together yet, but if I had my my way of doing this, I would think we would just throw everyone into a big pot so they know how they're performing compared to everyone else who's ordering similar studies on similar patients.
And one last question for you, Lee. Do you have at St. Joe's a standard way to document children with minor head injuries, either document in the body of the history and physical or the medical decision making? I'm just curious.
So I think that's a key point. And right now we do not. We have shared the dot phrases that people can copy and paste when they choose to do so. So we've not mandated you must put in this PCARN dot phrase that we've developed. We've shared it widely. It's readily available, but people don't tend to use it. And since our scores are okay, we're not mandating that. I think if we start seeing more and more fallouts, that may be the next step. But those are not automatically populated in the chart. And I think that's where the big win is. If my partner could open up a their note, and Epic recognizes the age of the patient and it's a minor head injury, then they can put in the dot phrase or whatever we create. So it really kind of is real-time direction to the providers to really assist them in their clinical decision making. So that I see that as a big part of the future of where real-time interactions go.
Can you just tell us before you jump off the call, I know you got to go, what do you think the biggest barrier is in your system or even any other system in terms of engagement for generalists versus the pediatric focus providers?
I think it's really the rarity at which they see pediatric patients with any specific diagnosis. So in looking at our data, we were really surprised, but patients who would fall into the intermediate risk group, it's single digits who really fall into the metric. And if you take these single digit patients and you spread them out over the month, all times of day, a single generalist provider may see one patient with an intermediate head injury every few months or more. So they're just not seeing a lot of these kids. They're not generating that comfort level with the decision making. And in this case, when PCARN has this opt-out for the intermediate, which we call low risk group, it's easy for them to say, well, PCARN says I could scan this child. And a lot of them just feel safer doing that because they're not as familiar with kids. And that's one of the distractions from having a nested pediatric unit is the people who staff that area see kids all the time and we're very comfortable with it, even our generalists who choose to spend time in that unit. And when others are kind of thrust into the pediatric environment, it takes a while to kind of get up to speed. So I think it's just general comfort and ongoing repetitive engagement on these measures. The big thing is the why. We'd like to compare to other groups in our systems to say, hey, here's a group of generalist emergency physicians who are knocking it out of the park. We can do the same. And I think once we kind of show people that generalists can do this and are doing this, people tend to buy in.